the functions. I think there's somebody who needs to mute, please. Describe the functions of the leukocytes, classify the disorders, and we'll just simply classify the disorders, because in the next series of lectures, you're going to go into a bit more details about these white cells. And then we shall also outline the investigations that are performed in the leukocyte disorders. Now, we'll classify the total white cell counts, the reference range for these in the blood. I think you may have had a lecture on the peripheral blood, but it's about 4 to 11 times 10 to the 9 per liter. That's the reference range taken from Western literature. And we do know that in many of the African races, we have a slightly lower white cell count, which is about 3.5 to 10 times 10 to the 9 per liter. So if you read literature from sub-Saharan Africa, you will find that reference ranges are typically lower than what they give for Western literature. And at Kenyatta, we use about 3.5 to 10 as our reference range. The white cells consists of the granulocytes and the mononuclear cells of the agranulocytes. Now, the granulocytes, which are also the polymorphonuclear cells, meaning that the nucleus is segmented, consist of the neutrophils, which are the majority that we find, eosinophils, and basophils. So those three groups of white cells. And then we have our mononuclear cells, and these are typically known as agranulocytes. And these are the monocytes. We shall go into details later when talking about the laboratory features, about the distinguishing features that we see between these two, or these 5 groups of white cells. Because by recognizing them, then we're able to associate elevations or decreases of certain cells with certain conditions. Revise our leukopoiesis. This helps, especially when the first progenitor cell that is present is the hemopoietic stem, and this is a multipotent stem cell, meaning that it can give rise to any of the blood cells. Under certain stimulus from cytokines, and some are shown there on the left, the factor, interleukins, 1, 3, 6, and 11, and the FLT3 ligand. These are early acting cytokines that will act the multipotent stem cell and cause it to proliferate itself, but also to differentiate along different, if at any time I lose you, perhaps one of you could just let me know that you're not hearing me, because it seems my internet is a little bit unstable, okay? So once the cell differentiates, it now gets committed into either the lymphoid or the myeloid, all right? So that there's lineage commitment. Lineage commitment is important because if you don't have lineage commitment, the cell cannot now differentiate into lymphoid or myeloid. It will remain as a hemopoietic stem cell, multipotent stem cell. Then under the lymphoid, after lymphoid commitment, Then you have certain cytokines which will promote these cells to either follow the B cell lineage, and interleukin-7 is important of this. It will enhance or the maturation of committed progenitor cells. And then you have interleukin-7, 1, 2, and 4, which are important for T cell lymphopoiesis. For the myeloid, granulocyte macrophage colony stimulating factor, or GM-CSF, is important. And this will encourage the cells to mature along the granulocyte and macrophage lineage. And these interleukins, cytokines, like including interleukin 3, 5, KIT ligand, and CSF1, will cause the granulocyte progenitors to multiply and as well mature till you get the mature granulocyte. And once you have maturation to the mature cells, these cells do not divide, okay? They are now fully mature cells and will not be dividing. Then you have the monocyte macrophage progenitors. These are encouraged or proliferation under the colony forming unit, granulocyte macrophage. And now this will cause these to proliferate and mature into your monocytes, which are in circulation these monocytes will leave the blood circulation and go into tissues where they become macrophages. So the circulating monocytes are the cells which will go into the bone marrow, and they will settle there and become macrophages. So in a nutshell, that is hemopoiesis, just to revise what you've already had. So let's start off or kick off our talk with the phagocytes. And the phagocytes are the granulocytes and macrophages. And under this, we also consider the monocytes. And these are the cells that are well trained to engulf and digest particulate matter. They are all derived from the bone marrow, as we saw when we were talking about leukopoiesis. So these are bone marrow derived cells, and they are functioning matter. So and also inflammation. So these cells will secrete, will start to call or to recruit other similar cells to the site of infection or inflammation. And they also will be able to digest senescent or the aged cell, any aged cells or cellular debris at the site of infection. So once there is infection or inflammations are quickly recruited to the site where there is these other cells to the site, so that there is a rapid mounted response to or inflammation. So as I said, macrophages, they detect, phagocytose, and destroy bacteria, harmful organisms. And they are also known as the antigen-presenting cell. That means that once it will engulf the bacteria or the harmful organism, it sets this to the T cell, all right? Because the T cell itself does not respond directly to antigens. When this antigen is presented to the T cell by the macrophages, it will now bring on the T cell response. and initiate inflammation by releasing cytokines, which can also activate other cells. These are very important cells in our immune response. So besides just phagocytes, they actually present antigens. Now, phagocytosis is mediated by macrophages and the polymorphonuclear leukocytes. And remember, we said the polymorphonuclear leukocytes are phils, basophils, and also the Z. And so therefore, all those three types of cells are able to phagocytose bacteria and other solid or other particulate antigens. So for example, sometimes if there is a particulate, like we went for theater and a bit of the powder from the glove landed in the tissues, that powder will be removed by these phagocytes. They will come and engulf. And this involves ingestion particles, damaged or dead host cells. So where there's inflammation or this is removed.
Hello?
Hello, yes.
I'm sorry, your connection.
I can hear you.
Yeah, your connection was really fluctuating at this point.
Unstable.
Is it to do with Wi-Fi or?
Okay. No, yes, it's to do with my Wi-Fi, but let me see if I can use my phone as a hotspot.
Okay.
It's not very stable, right? Okay, I've just sent for my phone. I didn't have it, so can you hear me now?
Yes.
Okay. Once I get it, then I'll. Where did I lose you? Phagocytosis?
That's about, yeah.
Okay. All right. Okay, so phagocytosis is mediated by macrophages and the polymorphonuclear leukocytes. And through this, there is ingestion and destruction of any microorganisms, any insoluble particles. I gave you that example of if somebody was doing an on and some powder from the gloves landed at the operation site. It doesn't just sit around there. It will be removed phagocytosis by the macrophages and polymorphonuclear leukocytes. Any damaged or dead whole cells. Whenever there is tissue injury, it can either be through infection or inflammation. The dead tissue will be removed again by these cells. Any cellular debris that is remaining and any activated clotting factors. So you can see by knowing what what can cause or these aspects about phagocytosis, then when it comes to knowing if the patient has elevated white cell counts, you will know some of the reasons that can cause these certain cell types to have their the cell counts increased. And we'll go into that in a little bit. Now, there are several stages of phagocytosis. So the first one is the chemotaxis. This is where the organisms secrete or will secrete some chemicals which will induce the white cells to move towards the site of infection or inflammation. Then they will adhere. Now, you know that the white cells will be circulating in the blood. They will then adhere to the area where, in the vessel, close to the area where there's that infection or inflammation, and then they will move out through the blood vessel to washing. Then they will form pseudopodium, where they will engulf the organism. I can see my internet is unstable. Okay, can you still hear me? Hello?
Yes. 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 Yes, we can hear you.
Yes.
So they will form pseudopodium and a phagosome. A phagosome is a mention of a structure within the cell which will include the material. I'll show you that in a diagram. And then the lysozymes from the cell will now join in with the phagosome. The lysozymes are the ones that contain the enzymes, they contain hydrogen peroxide, oxygen species, peroxidase, and line, and they will then, those are the ones that will actively destroy the bacteria that was contained within the phagocytosed in the phagosome, which was the phagocytosed bacteria or harmful particular organism. And then the oxidative burst, this leads to digestion by the phagolysosome contents and later elimination by exocytosis. So after there is digestion, most of the digested remnants are soluble, and this will be released, and then they will be excreted from the body. So if this is the diagram of the phagocytosis. So you can see here, I'm not sure if you can see my pointer, but the bacterium now lands receptors on the phagocyte, which is the macrophage or the neutrophil, and these will then enter. So pseudopodium are formed, and you can see this pseudopodium which goes to engulf this bacterium, and then that forms the phagosome. Okay, it is internalized to form the phagosome. Then the lysozyme, which was already in the cell, now comes in, joins in with the phagosome to form the phagolysosome. And the lysosome then releases those enzymes and peroxide, and these now digest bacterium or the dead tissue, leading to soluble debris, which will be by exocytosis. And now this will be able to blood and go now through the kidneys and be excreted, usually excreted through the kidneys out of the body. All right, so again, you will be able to revise later on phagocytosis because it's important when we're talking about the neutrophil function and the monocyte functions, and also the eosinophils. Now, the neutrophils are the largest group of white cells in an. You will see later on that in children, lymphocytes are the predominant white cell group. And the normal range for the neutrophils is 2 to 7 times 10 to the 9 per liter. And they form about 40 to 80%. So that you can see it is a range. So anybody having 40% neutrophils, that is still within normal. And they take about 14 days to mature in the bone marrow. And within the bone marrow, there is what is known as a storage pool. Now, a storage pool, and even in peripheral tissues, you do have a little the circulating, some storage also. Now, this storage pool is a store where, or rather, you have mature neutrophils that are sitting in the bone marrow. They're not being released in the blood vessels for circulation. This storage pool is the reason why when you have an infection, you don't have to wait 14 days for the neutrophils to mature in order to mount a response. So if you got infected, within a few hours, you will find that the neutrophils are increased. You will find that the neutrophils are increased very rapidly. Do a lot of vigorous exercise. You will find that your neutrophil, their neutrophil count will rise almost instantaneously or very quickly. This is because of release from this storage pool in the marrow, all right? So that's an important aspect to remember, especially when we're talking about the response to infection. And in circulation, the neutrophils have a short they circulate for a short time and then they're removed in order to maintain the normal neutrophil cut. The circulating neutrophils do not stay long in circulation. They are quickly removed, they age, they are removed, and at the same time, others are coming. But we have this storage pool, mainly in the marrow, but we also have some in tissues that can allow for a very rapid response to infection. Now, the major role of neutrophils, agents, and it's especially bacteria, all right? And the capillaries by margination in between the endothelial cells. So the endothelial cells, or the lining of the capillaries, this endothelial cells, and there are small gaps, very tactic stimuli. They're able to move in between these, squeezed out in between these cells by, that's called diapedesis and extravasation, that they're leaving circulation, and then now they will carry out their phagocytic activity. Is neutrophil action.
Hello, Prof.
Regulated. And can hear you. Has the signal gone off again?
Yeah, it was really interrupted for the past 30 or so seconds.
Oh dear. And I can't just seem to locate my phone. I don't know, I must have left it somewhere. Okay. But I will send you these slides later on. Okay. So where did I lose you? Neutrophil function, regulation. Okay, we'll talk on the regulation of. So the cytokines are the basic regulators of all neutrophil functions. All right. So this regulation of function is through cytokines. And if we remember when we were talking about cellular function, that all cellular function in the body is under regulatory mechanisms, which is important because if you don't have proper regulation of cells in the body, then you begin to get disease. So if you have excessive stimulation of the cells, then you have excessive inflammation, and this can manifest as a disease process. By the same token, if you have where your cells are not stimulated at all and you don't respond, and that can happen, especially where you have abnormal neutrophils that are, functionally abnormal because they have functional abnormalities. Maybe they don't have they're not morphologically normal, then they're not able to respond to cytokines. Again, you're liable to get disease. So therefore, in order for normal function, we must have normal cells, and then we must have close regulation of the function. And we will see that cytokines, you can see my internet is now unstable again. Sorry. Cytokines are the basic regulators of all neutrophil functions. And the neutrophils, besides responding kinds that may be released by the macrophages, if you remember, we said macrophages will be found at the site of inflammation and infections, and they will release cytokines, which will draw other macrophages and neutrophils towards that site of infection. Neutrophils themselves also will secrete small amounts of cytokines, and these will be activate other neutrophils. They will cause other neutrophils to migrate there and will activate them. And these cytokines include interleukin-1, interleukin-6, 8, tumor necrosis factor or TNF, and granulocyte macrophage colony stimulating factor. So all those cytokines are also synthesized and released by neutrophils. And these are pyrogenic, and that means that they're the types that cause fever to occur. They're pro-inflammatory. They will cause other inflammatory cells to migrate and release inflammatory cytokines and inflammatory molecules. And they will also activate other neutrophils. The cytokines that are released also increase the microbiostatic and killing capacities of the neutrophils against bacteria, protozoa, and fungi. So these cytokines not only cause neutrophils to migrate and etc., but they enhance the function of the neutrophil in causing, preventing bacteria from multiplying and also killing the bacteria. Okay, as well as protozoa and fungi. So you can see that although we often talk about neutrophils and bacteria, they're also important in protozoa and fungi protection against protozoa and fungal infection. So the other group is the eosinophils, and these are also polymorphonuclear leukocytes. They are about 0.02 to 0.6 Some groups or some individuals do take up to 1 × 10⁹ per liter as the upper limit, although most people will take 0.6, all right? And the percentage is usually about 1 to 6%. They are produced in the bone marrow, and they take about 8 days to mature. Again, you can see they take some time to mature, and therefore there is also a storage pool in the bone marrow, so that if I am introduced to, say, something that makes me allergic, like some pollen, for example, if I'm allergic to pollen, eosinophils do not wait until 8 days till they mature, but will be released almost immediately in response to that allergen. And you will later be learning about the things that cause eosinophils to increase. I just gave you allergy or allergic situations as one. Interleukin-5 is a key cytokine in the maturation, survival, and persistence. So these interleukins will also help the survival of these cells where they have been called to go and fight, say, a parasitic infection, and also help them persist in that area where there is that infection. Other cytokines that are involved are granulocyte macrophage, colony stimulating factor, interleukin-3. And the half-life, sorry, that has run into each other, but this was to talk about the half-life. This is very similar to that of, however, the lifespan in tissues of eosinophils can be up to several weeks, and like that of the neutrophils, which tends to be a few hours to days, in the tissues for the eosinophils, it takes up to several weeks and they can persist. And therefore, when you are doing your anatomy and you are doing the gut, you found that there are eosinophils that are often found close to the gut or to the pulmonary system, etc., because these are areas that are exposed to the external environment. Okay, so the gut, the respiratory system, and even the urogenital system, where they're exposed to the external environment, you will find that eosinophils may persist in tissues there. And sometimes where we have situations where there's an increase in the eosinophils, we may find this specific type of cell known as Charcot-Leyden crystals that are seen in areas of eosinophil degeneration. So sometimes if somebody has a massive allergic reaction and they give their sputum, we can look at the sputum. Let me wait for my internet. Okay, we can look at the sputum if somebody has had an allergic reaction and they are coughing or they're having wheezing, stain it and look for these crystals that will show or indicate that there has been increased numbers of eosinophils that have degenerated. So the eosinophils will move to inflamed substances and killing cells. They are very important, especially in anti-parasitic and bactericidal activity, participating in immediate allergic reactions, and modulating the inflammatory response in relation to the parasitic and allergic reactions. So because of this, you will see that when we talk of eosinophilia, allergy, parasitic infection, etc., are causes of eosinophilia. The migration and movement of eosinophils is promotokines. That is some of the chemokine examples: TL11, CCL24, and CCL26. and the receptors of chemokines. And therefore, in antiparasitic and inflammatory responses, the eosinophils will suppress immediate hypersensitivity reactions. They include the immunosuppression of that, and they also respond to certain tumors. And you will see that, especially where you have tumors and you have necrosis of these tumors, you will tend to get a rise in eosinophils as they respond. And again, just like the neutrophils, they will be activated hemotaxis, which will lead to the eosinophils migrating to the site where there is the harmful organism or harmful or noxious agent, and then they will degranulate. And degranulation, these granules and enzymes, which will then attack the bacteria, or especially the health of the parasite. Then these tend to be few, 0. Usually less than 1% when we talk of the relative numbers. So for a long time, very little has been known about basophils, but more and more light has now come. We know they mature in 7 days, again, very similar to the eosinophils and marrow. They have vasoactive and immunomodulatory chemicals within their granules, such as histamine, and these are usually released by basophils and also other cells, which are the tissue mast cells, which are very closely related to basophils, including the bone marrow. And these chemicals, such as histamine, cause capillary and certain hypersensitivity reaction. And they complement. So they do have an important role. Although when we actually do look at basophils in day-to-day life, they do not seem to, when we are analyzing them, etc., because of their very few numbers, not much attention has been paid to them. Monocytes. The monocytes represent 0.2 to 1 times 10 to the 9 lit per liter. And again, very important cells. They are phagocytic. Certainly migrate into become tissue macrophages. And once they migrate, their lifespan can be in terms of months and years. So when you are doing your anatomy, I'm sure you came across Kupffer cells in the liver, the microglia in the brain, the mesangial cells in the kidney, and the osteoclasts in the bone. These are part of the macrophage. Phagocytosis is mediated by macrophages and polymorphonuclear leukocytes, as I said. So remember that the tissue macrophages are found almost in every single tissue, all right? Therefore, telling you that the ability to protect itself, tissue's ability to protect itself relies as well a lot on the tissue macrophages that are present. And many of these originate from the circulating monocytes in the blood. The lymphocytes, there are two broad categories of lymphocytes, the small lymphocytes, B and T cells. And then you have large granular lymphocytes, which are the natural killer cells. Now, remember, we often tell you that lymphocytes do not have granules, they are agranular. That is true for generally your B and T. However, we do know that there are some larger lymphocytes which tend to have large aerophilic granules, and these are the natural killer cells. The B lymphocytes within the bone marrow, and remember that the bone marrow is considered amongst the primary lymphoid organs, or a primary organ. And then the T lymphocyte in the thymus, which is also a primary lymphoid organ. So you have these two places where these two secondary lymphoid tissues. Now, these are the spleen, the lymph nodes, which are found in several tissues or close to several tissues, and organs, and adenoids, tonsils, and mucosa-associated tissue. Okay, also known as MALT, mucosa-associated tissue. So these are the categories of sites that are very important for our immunity in the body. So how do they achieve, or how do we achieve this immunity from the lymphocytes? The lymphocytes will respond to antigens. And remember, these antigens are the ones that are presented by the macrophage. The lymphocyte does not respond directly to the antigen itself, but the antigen that is presented by the macrophage. And when this antigen is presented by the macrophage, the B lymphocytes, or the B cells, respond by becoming plasma cells and producing antibodies. So the B cells are therefore in charge of antibody production. The B and T cells both produce lymphokines. And these lymphokines, as we have been seeing, very important in controlling the immune response by secondary action on all the other cells. They have action on the neutrophils and the macrophages. The lymphocytes are very key in the killing of virally infected host cells, all right? And the subset, okay? So the lymphocytes are very important in the killing the virally infected host cells, and the subset of cells that are key for this function are the cytolytic T cells. So the T cells are involved in this cell-mediated immunity, whereas the B cells are involved in immunity or the antibodies. Now, I don't know if you've had immunology lectures in this, but in immunology, you're going to go into a lot more details about the different lymphocyte subsets and humoral and cell-mediated immunity. So the cell-mediated immunity, the T cells are the ones that are going to be killing the virally infected host cells. As we saw, the bacteria or the neutrophil is not going to be able to kill the viruses. It is more involved in the particulate immunity or particulate response or response to particulate bacteria and substances, whereas the T cells are important in your viruses. And therefore, later on, when we're talking about what causes increase in lymphocytes counts, you will see viral infection is one of the causes of an increase in lymphocytes. Natural killer cells, they're part of the cell-mediated immunity, the innate immune response. And this innate immune response is the immune response which is there at birth, is not dependent upon the antigen virus having previously been presented to the host, all right? It is innate, it is just there and not dependent upon having the virus or to, it's not like a secondary immune response. And the natural killer cells will attack on the particular cell surface. So when the virus attacks certain viral antigens to be, or changes on the virally infected cell, and therefore this change in antigenic material on the host cell will be detected by these natural killer cells, which will then mediate in the killing or the attacks infected host cell. Okay, so I will now go to show you what the cells look to, how we detect or how for our white cells. This is and as you can see, compared cell, it is a large, in actual 3 times the diameter of the red cell. We said it is segmented to 5 lobes, okay? This one has 3, and you can see in the cytoplasm looks pinkish. This is because there are very fine azurophilic or fine purplish granules all through the cytoplasm, okay, distributed evenly through the cytoplasm of this cell. So that is how we describe a neutrophil. The eosinophil, again, polymorphonuclear. This one has, it almost looks like it's got 3 lobes, but it has actually 2 fully formed lobes. Normally has 2 to 3 lobes, but may have 4 or may have less. And you can see that the cytoplasm in this case is densely packed by coarse granules. These are not fine granules like the neutrophil. These are coarse granules, and these granules are described as reddish orange or salmon pink. Again, when we finish the lecture, I will encourage you to go onto atlases. There are several good descriptions in the internet, and you can see, you'll be able to see the color of these reddish orange or salmon pink granules. That's the major differentiation between the eosinophil and neutrophil, are the granules in the cytoplasm, not the nuclear lobulation, but the granules within the cytoplasm. And that's where the name eosinophil comes from. It means it takes in eosinophil, it's an acidophilic granule. Then we come to the basophil. you can see that generally the basophil is also segmented, may have 2 segments, or 1 not segmented. Mute, please, whoever is online.
I wanted to sleep here. I know. Yeah.
Oh, it's not who's not muted, please mute. And you can see the basophil, called a basophil because the granules are basophilic. They're deep purple black. They're described as purple blackish granules. They're very coarse. By coarse mean that and they cover the whole cell, including the nucleus. They obscure the nuclear appearance, all right? So that is what basophilic granules look like. So when you come to your practicals, you have a chance to look down the slide and identify these different granulocytes. Then we have the other cells. We have the lymphocyte, and we know that it's the smallest circulating white cell. You can see that in this case, the of them is just slightly larger than the red cell. Sorry for my connection. The nucleus is just slightly larger than the red cell. And you will note that the nucleus almost fills the whole cell. There's a high nuclear cytoplasmic ratio. The lymphocyte is not, the nucleus is not segmented, unlike the polymorphonuclear cells, and it has a thin rim of basophilic or sky blue cytoplasm, all right? And this is the typical appearance of a small lymphocyte. You cannot tell whether this is a B or a T lymphocyte just by looking at it, all right? You would have to do your flow cytometry in order to see the antigenic markers that will be able to tell you that this is a B cell or a T. The last cell I'll describe is your monocyte, cell in circulation. You can see it is about 4 to 5 times the diameter of the mature red cell. It has a nucleus that is either variously as horseshoe-shaped or kidney-shaped. So generally, the nucleus is sort of irregular, either brain-like, horseshoe-shaped, or kidney-shaped. Tends to have plentiful cytoplasm. This cytoplasm is not really typically described, but seems to be what we say ground glass appearance. So if you took glass and you ground it, it looks sort of particulate, but not quite particulate. And the color is described as blue-gray or dirty blue or dirty gray, all right? So those are some of the descriptions we use when describing the monocyte. Now, I would like you to, to practice describing the cells to yourselves, because if you are to describe a cell to me, accurately need you to tell me that this is a monocyte, a neutrophil, or a eosinophil. I should be able to say from your description, you have described an eosinophil or a monocyte or a lymphocyte, okay? So learn those descriptions, because that is what we use, especially when we're doing our reporting or looking or identification of cells in hematology. Now, finally, or just before we go how to investigate, how do we classify the leukocyte disorders? We classify them as per the quantities. Is it a quantitative or numerical abnormality? Or is it a qualitative? Qualitative means, is it a functional or morphologic abnormality? So quantitatively, if we're talking about the quantitative abnormalities, we're talking about whether the leukocytes are increased or reduced. That is leukopenia. Leukopenia is the term we use for a reduction in the white cell count. Leukocytosis is a term we use for a rise in the white cell count. Now, the leukocytosis may be either benign, meaning that it is not due to cancer, such as like if there is a reduction in an increase in the production due to, say, infection, or it may be neoplastic. Neoplastic is when the rise in the leukocytes is because of a white cell cancer, and the white cell cancer is known as leukemia. All right? We will learn a bit more about the leukocyte disorders in the next lecture. Now, the qualitative abnormalities are either you may have a functional abnormality in that the function of the leukocytes is abnormal. Very often, this may be accompanied by a morphologic abnormalities in that the morphology of the leukocyte, whether we can look at it by light microscopy or electron microscopy, the function is abnormal, right? And having quantitative and qualitative abnormalities are not mutually exclusive. That means you may have a leukopenia, and that the leukocytes, besides being reduced, are also functionally or morphologically abnormal, all right? So those two are not mutually exclusive. And very often when we have neoplastic rise in our leukocytes, it is accompanied by a functional and even morphologic abnormalities. So what are the tests for the white cells? We will do our blood counts, and we will do the total and the differential set counts. And remember the differences between the absolute and the relative. Now, you can tell me in your chat if you don't understand the difference between absolute white cell count and the relative white cell counts, okay? Peripheral smears. This is where we look at the stained blood film, a very important aspect of looking at the morphology of the white cells to detect, are they normal, are they abnormal? And if they are abnormal, what is the abnormality that is present? We look very often at the bone marrow because this is where the white cells are produced. So if, for example, we see abnormal white cells that look like they're malignant, we will always look at the bone marrow to see, because that is where we should be seeing these abnormal white cells being produced. Then we can do special tests. This is known as cytochemistry. These are special dyes or special stains that we use on the white cells, and these can help us identify certain white cell abnormalities. And later on, you will be discussing what are these kind of tests that we do. We can also perform functional tests. Very often, these will be done in the immunological or the immunology lab, where they look at either the neutrophil, phagocytic activity, etc. There are molecular biology tests, and this other is which now where we can look at we can do PCR tests to look at the DNA characteristics of abnormal cells, or looking at especially some of the genetic abnormalities of these. Sorry, I forgot to put in here flow cytometry. That needs to be included, and I will put that in this handout when I send it to you, the PowerPoint slides. Flow is an important aspect, and you will remember when I told you if we want to differentiate B from T cells, we can by flow cytometry. Mature cells, we can do flow cytometry to identify those different cells. Then we can also do cytogenetics. Again, this is looking at the kind of chromosomes that are found, especially when we're talking about the neoplastic or the cancerous white cells, where we often do cytogenetic tests to look for the abnormalities that are present. That shell, those are the tests that we perform for white cell abnormalities. Thank you. I apologize for, I'll have to look for some source of internet because stable, but I will be able to share these slides with the class. Okay, there are some questions. I can now take any questions. So Abdirazak, sorry, I've murdered your name. Now, why are neutrophils released from the storage pool during exercise? All right, so during strenuous exercise, or it can be other forms of stress, the neutrophils are released because, remember, when the body is or encounters a stressful situation, it can be excessive exercise, it can be severe stress, can be severe emotional stress, can be a fright. There is release of adrenaline, and this will cause the flight kind of response, fight and flight response in the body. The release of this adrenaline is one of the things that can cause the neutrophils now to be released from your storage pool. So when you have any types of intense stress, the adrenaline and other similar chemicals that are released will cause the release of these neutrophils from the storage pool. Okay, vigorous exercise, breakage of some muscle tissues, yes, and we can say to respond to post-exercise trauma, even before the trauma. If now I found something terrible happens suddenly, even like in shock, you can get, when you're in an accident or you have tissue damage, etc., the release is almost immediate because of the release of adrenaline and similar molecules, okay? Do natural killer cells contribute in autoimmune diseases? Yes, they do. yes, they are part of the response in autoimmune diseases, okay, in the cell-mediated destruction. Okay, very good. Somebody has also asked, they don't understand the difference between absolute and relative counts. That's a good one because I really want you all to understand. Now, when we talk about the neutrophil count, remember we said the normal neutrophil count is between 2 to 7 times 10 to the 9 per liter. That is an absolute count. So if I told you my neutrophil count right at this moment is 3 times 10 to the 9 per liter, that is an absolute count. It is the exact number of neutrophils. However, if I said I have 20% neutrophils in my blood, that gives me a relative or a percentage. So I don't need absolute numbers. I just know that it is a percentage. If my total white cell count, for example, was 5 times 10 to the 9 per liter, and I said 50% are neutrophils, the absolute neutrophil count would be 2.5 times 10 to the 9 per liter, which is 50% of 5. And therefore, the absolute count is the one that is very important when we are talking about things like a rise or a fall, neutrophilia or neutropenia. So, for example, if I said I have 90% neutrophils, I cannot assume that is neutrophilia or increase in neutrophils because my total white cell count might be only 1 times 10 to the 9 per liter. And 1 times 10 to 9 per liter is a low white cell count. And even if I take 90% of that, it's only 0.9. Okay, so when you come later on to talk about whether the cell there's an increase or a decrease in a particular subset of white cells, use absolute counts, okay, not the percentage or relative count. Does that explain, Abdul Rahim? Okay, cytogenetics and molecular biology. Okay, so cytogenetics is actually looking at the genetic of the cells. Some of the cytogenetic tests include chromosomal, analyzing the chromosomes, okay? And if you remember, you had 46XY, but if you look at the chromosomes, you can do special tests, like you can stain these, you can grow these or culture these cells, stop the chromosomal at mitotic stage, and then stain them, and then look at the chromosomes, and you're able to detect where there might be some deletion of a chromosome or part of a chromosome, etc. That would be a cytogenetic test. That's what we call karyotyping, or looking at the chromosomes. Now, the molecular biology include your molecular cytogenetic test, because most people, when they talk of cytogenetics, they're mainly just thinking about this chromosomes. But when you talk of the molecular cytogenetics, you're looking at a point mutation, which you will not be able to see when you're doing your chromosomes, because it's too small to see, all right? And that point mutation can be done by PCR, which would include your molecular biology tests, okay? Now, what we would do, these tests are very important, especially where we have some inherited abnormalities of white cells, and very so important in the neoplastic or the cancerous or the leukemias. And you're going to learn this about these, especially when you start learning about the leukemias, how critical doing these cytogenetics and molecular biology tests for the white cells, because these abnormal cells have abnormal DNA, okay, or abnormal chromosomes, and that's what what initiates the abnormality, okay? So Vivian, I hope that has explained to you. Let me know if not. Muruki, differential count to give the percentage, very good. The differential counts that we do on the peripheral blood film and you're looking at that and you're counting.
That's Misha.
Yes. Sorry? Can you mute Faith, please? Okay. So the differential count, as we're looking at our PBF and we're noting the different types of white cells, yes. However, you will see when you come to hematology, our equipment is very sophisticated and is able to do a differential count for you and also give you absolute counts for neutrophils, eosinophils, and basophils. This is because the machine is able to use methods to detect the morphological features of these cells and therefore give you fairly accurate differential and absolute counts. So very good absolute counts. That's quite right, Morioki Mwenda. Abdul Rahim, okay, thank you. When is the relative count used? Now, very often, relative count may be, someone may say, oh, there is a relative lymphocytosis. That means that even though your neutrophil count is within normal and your lymphocyte count may be within normal, that there is an inversion. Instead of having most neutrophils and fewer lymphocytes in an adult, you may have 60% lymphocytes and say 40% neutrophils or something like that, all right? However, we avoid using relative lymphocytosis, etc. We prefer talking about absolute. But now and then relative may be used. But for your purposes, when you're the doctor in the ward, I would expect you to say, yes, there's an absolute neutrophilia or there's absolute lymphocytosis rather than relative, okay? But sometimes in some viral infection or something, you may get a relative lymphocytosis, but we like more someone to focus on absolute counts. Main reason we do full blood counts. All right, that's a good question. Before you go for open surgery or for major procedures, why do we do a full blood count? Now, later, as when you go to the wards, you will find that there are some or quite a number of cases where patients may present, and even though they look normal or they look healthy, there may be abnormalities. And there are some clinical settings where these abnormalities may be detected by doing a full blood count. So it's almost like a screening. So if you are going for, say, or say a hernia, most times we expect this person to be perfectly normal. However, there are instances you may be able to detect abnormalities. And before surgery, we always like to evaluate a patient to ensure that this patient is healthy, especially, or they don't have any abnormalities we're not aware of. Whether the patient had, if a patient, of course, had an accident and they need to go for fixing of the nails, etc., you need to know their hemoglobin is normal. You need to know their white cells are normal, that there is nothing wrong with the white cells. You will see later on some conditions like chronic myeloid leukemia can present to the patient who looks absolutely healthy and also feels absolutely healthy. And you need to know this, okay? So the main reason we do this blood count is to ensure that our patient, before going to surgery, is healthy, or that there is no condition, hematologic condition that is underlying that we do not know about, okay? It is a check. Just before you go, like when you're going for insurance, some of the basic tests they will do are these blood counts to ensure that you're healthy, or to check that at least, you know, these are okay, all right? Okay, I don't know, any other questions? Okay, I will if you, I think I do have your email, so the class email. So I will also send this updated, I'll correct some of the things that I'd forgotten to put in the investigations. I will put them in, okay? All right.
That time.
Okay.